Welcome to Module 8, Mood Disorders, Depression. Please watch the TED Talk posted on Blackboard for depression. You need to hear it from the client who has depression. Mood disorders. Mood disorders are also called affective disorders. Why do you think that is? Affect is a psychological term for an observable expression of emotion. So, often we can see a person's affect. Can you see depression? Do you think you can see mania? Yes. Mood disorders are pervasive. Pervasive, if you don't know what that word is, please look it up. These disorders affect every aspect of a person's life. The disorder is ever present in all the thoughts, events, and fabric of their lives. The long-term sadness or agitation or elation is a tremendous stress on a person's psyche and their body. This is different than people who are unaffected by mood disorders. We all sometimes feel down in the dumps. We have anergia, A-N-E-R-G-I-A. If you don't know what that means, look it up. Or feel discouraged. Or, on the other end of the spectrum, we have days where we feel elated and exuberant. But there's a tangible difference between these transient feelings that people without mood disorders have and those that are affected by mood disorders. We still go about our daily lives, and our feelings level out. For the most part, our lives are in a state of emotional homeostasis. We're in a euthymic mood, and that's what's common for most folks. It's very important for you all to know, as nurses, that mood disorders are not just the most common psychiatric diagnosis in healthcare, but also the most common diagnosis associated with suicide, especially depression. Categories of mood disorders. The primary mood disorders are major depressive disorder and bipolar disorder. Because of the prevalence of suicide with both of these diseases, we're also going to briefly review suicide when we talk about bipolar disorder. What is major depressive disorder? Major depressive disorder is abbreviated as MDD, so you may see it that way. So how is it diagnosed? A person has to have 5 or more of the following symptoms during the same 2-week period, and at least one of these symptoms has to be the 2 that are dotted in red. So 5 or more symptoms, one has to be either depressed mood or anhedonia. What's that word anhedonia mean? If you don't know, you should look it up. So A, 5 or more of the following symptoms in a 2-week period. At least one must be depressed mood or anhedonia. And B, the persistent symptoms are pervasive. They cause significant distress and impair a person's life and functioning. And C, the episode is not attributable to the psychological effects of a substance or other medical condition. So, put A together with B and C, and you have a major depressive episode. There must also have never been a manic or hypomanic episode. If that's the case, then it's a different diagnosis. Some people with major depressive disorder also have delusions and/or hallucinations. Categories of mood disorders continued. Although we're not covering bipolar disorder in this lecture, let's review the symptoms of it because you need to understand how it's different than depression. What is bipolar disorder? Well, bipolar disorder used to be called manic depression, which is a pretty accurate description of the disease. The diagnostic criteria for bipolar disorder is a combination of the symptoms for depression that you saw on the previous slide and the other symptoms you see listed here. Usually the episode of mania is about a week, but it can last longer. Sometimes there's also delusions or hallucinations that accompany the mania. Remember, episodes of mania or hypomania are not associated with major depressive disorder, but with bipolar disorder, which is the next lecture, so hold that thought. Categories of mood disorders, related disorders. Persistent depressive disorder, which is abbreviated PDD. This is like major depressive disorder with a lot of the same symptoms, but your functioning is still intact. So it's like you have a milder version of the symptoms of major depressive disorder. You can still go to work. You can still accomplish some of your roles in relationships. However, persistent depressive disorder is also persistent. It lasts a long time. You'll hear people call this dysthymia. That's kind of an old-fashioned term. Folks who have PDD are at very high risk for developing MDD. Substance-induced mood disorder. This is a mood disorder that's brought on by a substance, usually drugs or alcohol. Seasonal affective disorder. This is like winter depression or summer depression. Both of these kinds of related disorders are treated with light therapy. Postpartum blues, postpartum psychosis, and PDD, which is premenstrual dysphoric disorder. This is a situational depression or psychosis that's related to a recent delivery of a baby. Postpartum psychosis is a medical emergency. I put a link to a story about it if you're interested on your non-voiceover PowerPoint slide. Just a reminder, links and videos do not work on your voiceover slide. You'll have to go to the hard copy that's on Blackboard. Please click on all the links. They're valuable and they'll help you understand all of these diseases. So back to postpartum blues, psychosis, and premenstrual dysphoric disorder. PDD, premenstrual dysphoric disorder, affects about 20 to 30% of premenopausal women. And to be diagnosed with it, you have to have severe dysfunctional PMS. Non-suicidal self-injury. Non-suicidal self-injury is cutting, burning, self-mutilation. This is also seen in borderline personality disorder. Where does depression come from? What's its etiology? First, let's look at biological theories. Depression is a medical illness that cannot be controlled voluntarily. That's pretty much the upshot in every theory. So what causes it? Most theories suggest that there's a genetic predisposition, and if this genetic predisposition is combined with a significant stressor like abuse, poverty, chronic illness, or a history of depression, then you're more likely to develop and have depression. Genetic theories. On genetic theories, our evidence implicates the transmission of major depression in first-degree relatives. So if one of your first-degree relatives has depression, you have a greater likelihood of having it. But again, when you look at genetic theories, not all monozygotic twins, both of them have depression. One may have depression and one may not. This kind of explains a little bit of the nature-nurture combo theory. Biochemical theories are that serotonin and norepinephrine are two major biogenic amines implicated in mood disorders. In short, you have too little serotonin and decreased norepinephrine activity in depression. And if you don't remember what those amines do, you should. Please go read your anatomy again. Hormones. Hormones may also play a role in depression. About 40% of folks with depression have high cortisol levels. And up to about 10% of folks with depression also may have a thyroid dysfunction. They have too much thyroid stimulating hormone. The underlying disorder has to be treated if it is a hormonal problem for successful treatment of the depression. The picture you see there is a PET scan of a person with depression, with and without medication. Look at how much more active their brain is when they're on meds. Anatomical theories. So anatomically, imaging has shown us that there are anatomical differences in depression. In depression, folks have smaller frontal lobes, larger cerebral ventricles, and possibly thickened brain tissue. Etiology, psychosocial theories. So one of the psychosocial theories that's popular right now is the stress and predisposition model. Predisposition is diathesis. The stress and predisposition model, this is nature plus nurture, says that you have a vulnerability. Go back and look at your biologic theories. So you have a vulnerability that's combined with stress from a life event and a lack of protective factors. What are protective factors? Protective factors are things like having friends, like having a job, like having a purpose in life, like having maybe you belong to a church or a volunteer group. So if you have these vulnerabilities that's combined with stress and a lack of protective factors, this may actually cause physical changes to your neurology, and that may cause depression. Etiology, psychosocial theories. So there are various other psychosocial theories. There's probably hundreds actually, but let's look at 3. Freud. Freud says that depression is anger turned inward. Anger can be related to a real or perceived loss. Basically, Freud says it's the victim's fault and there's some deep psychological reason, but it's still their faulty thinking. Why am I telling you about this? Most folks have rejected Freud, rejected most of his stuff outright, but you're going to be taking care of older people that were raised on Freudian theory. And they may have a much more difficult time discussing their depression because they think it's their fault. Important that you know that. Cognitive theory. This is Beck. In short, negativity begets negativity. To change that, you must change your thinking, and that's cognitive behavioral therapy, or CBT. You have to ID the negative thinking, develop alternative thinking, and rehearse your new thinking and new behaviors. That's a really good little graphic that talks to you about how Beck says Beck's cognitive theory causes depression. So another one is learned helplessness. So in learned helplessness, stressors equal anxiety. Stress causes anxiety. Anxiety leads to a loss of self-control and feelings of self-loathing. The loss of self-control and feelings of self-loathing, that turns into depression. Let's look at some cultural considerations with depression. So depression can be masked by behaviors that people culturally consider age appropriate. So in children have school phobia or hyperactivity or learning disorders or failing grades or antisocial behavior. That could actually be depression. In adolescence, depression may be masked by substance abuse or gang behaviors or risky behaviors or eating disorders or some compulsive behaviors. Old folks, like the ones you see in that picture there, they may appear grumpy and cranky, but they're actually depressed. Remember, too, in different cultures, depression may manifest as somatic complaints, physical body complaints, especially among cultures that avoid verbalizing emotions. So, true or false? Depression is most commonly associated with suicide. Major depressive disorder. Let's look at our incidence and prevalence. The projected lifetime risk of depression by the age of 75 is about 23%. That means about 1 out of 4 people will experience at least one episode of depression in their lifetime. The incidence of major depressive disorder is twice as common in women versus men. Onset for depression, that's decreased more recently. It used to be when you were close to 30. Now it's usually starting about age 14 to 15. Remember, more people who have first-degree relatives who suffer with depression are prone to having depression than folks in the general public that don't have first-degree relatives with it. Depression is higher in single people than married people, and it's the highest in divorced people. Like most diseases, the earlier in life a person develops depression, the more severe it usually is. Most people that have a major depressive disorder will have a reoccurrence of the disease, and up to 20% will be chronic sufferers. So do you think you'll be taking care of people who have depression? You absolutely will, no matter where you end up working. Major depressive disorder and comorbidities. So, depression is seen in every area of the healthcare setting. It is sometimes secondary to medical conditions and is either caused or exacerbated by the medicines that we use to treat medical illness. About 30% of your med-surg patients will also have depression. About 40% of stroke patients will have mild to moderate depression. If the depression is untreated, don't you think that's going to impair their rehab and recovery? Up to half of Alzheimer's patients also have depression, and nearly half of patients with Parkinson's disease have depression. Substance abuse and depression is a chicken and the egg question. You know, which came first, the chicken or the egg? So which came first, the depression or the substance abuse? Did they self-medicate to treat their depression, or did the substance cause the depression? Other psychiatric disorders may present as depression, but they're frequently comorbidities, like you have anxiety and depression, or an eating disorder and depression. But the disease that presents is depression. The doctors have to look for underlying or co-occurring psychiatric disorders when somebody is diagnosed with depression. Oh, look, here's that slide again. Major depressive disorders. It talks about the signs and symptoms of MDD. I bet this is important. Listen, not everybody's symptoms are the same, too. Symptoms can range from mild to severe, so don't expect every one of your depressed patients to be the same. Some may be bedridden, and some may be very high functioning. Don't disregard their disease because they're able to go to work. Treatment, psychopharmacology. Depression is mostly treated with a combination of psychopharmacology, what a huge word, that just means meds for psych, and talk therapy. So meds and talk therapy. And on occasion, there may be other somatic or alternative therapies. Therapy that includes meds is effective for most people with depression. So about 65 to 80% of folks that take medication as part of their therapy, they get relief from their depression. Because remember, researchers believe that the levels of serotonin and norepinephrine are decreased in depression. So in short, the meds keep your synapses bathed longer in those neurotransmitters. And keep in mind that while all antidepressants work effectively, one may not work for a particular individual. The complex functioning of neurotransmitters is unique for each individual. So a variety of antidepressants or a combination may be needed or tried before an effective treatment is determined. People get discouraged because the first med they take didn't work. You have to reassure them that there's plenty of other medications we can try. How do doctors pick these meds, or nurse practitioners? Most medication for depression is actually prescribed by your family doctor. They have a very limited training in psychiatry. In fact, the Yale School of Medicine, which sounds amazing, right? You're going to see a doctor who went to Yale. They get 6 weeks in their entire medical school to do their psychiatric rotation. 6 weeks. So, because of this, often what you see is the family doctor may prescribe pills. So they'll prescribe the psychopharmacology, but they don't also prescribe psychotherapy. And they may not address the underlying coping or stressors that are contributing to the depression. Medication is replacing therapy as a long-term solution. So it's super important that you understand these meds. So how does the doctor pick the med? They pick it based on a variety of factors. The experience of the patient is one. Did they take an antidepressant before? If so, how did it work? Is this medicine safe for this patient? Remember, not every medicine works with everybody's other possible diseases that they may have. There may be contraindications with other medical conditions. Does the medication treat the specific symptoms associated with the depression? So is there anxiety involved? Is that medicine good for depression and anxiety? How complicated is this medicine to take? Can they take it themselves? Is there strict administration? Can they follow a special diet? Because some of the medicines that we're going to talk about require a special diet. Do they understand how to taper on and taper off a medicine? Can this patient live with the known side effects? Some of these medicines we're going to talk about severely affect your sex life. How important is that to you? Can you handle the weight gain that's associated with some of these medicines? Can the patient afford the medicine? Let's say you have depression and the specific symptom that troubles you is cloudy thinking. Your doctor may approve a new drug called Brintellix. Wow, what a great name. Which was approved in 2013 for depression, but it couldn't compete with the cheaper generics. So now it's being marketed specifically for patients who suffer with depression with cognitive symptoms, cloudy thinking, a loss of concentration, slow processing. Brintellix costs about $300 a month. Can you afford that? What else affects physicians? The same thing that affects all of us, marketing. Are doctors and patients affected by marketing? Absolutely. When Prestige came out in 2008, their sales were flat. The commercial that's embedded was all over TV. And in 2010 and 2011, the sales for Prestige were up 280%. That also landed it in the number 7 spot on the top most prescribed drugs. So the commercials stopped being played, and by 2013, it was number 47. And the last numbers that came out put it at number 97. I don't think we're seeing those commercials on TV. The commercial is embedded. Remember, you have to watch it on the non-voiceover version of this PowerPoint. I put a link to an article in there that talks about antidepressants and that there may not be cheaper alternatives coming out and prices may skyrocket. Psychopharmacology. So these are the medications that we're going to look at. We're going to look briefly at each class of antidepressant. You need to review the tables in your textbook that talk about antidepressants. You've got to know these side effects like the back of your hand. You have got to know your nursing interventions. Like, what are you going to tell a patient with a dry mouth? What are you going to tell a patient who has constipation, sleeplessness, sleepiness, nausea? You've got to know these common side effects and know what teaching you have. Now, very important. Our biggest concern with anybody that's starting an antidepressant is the risk for suicide. Why, when somebody starts an antidepressant, are they at an increased risk for suicide? Well, the fact of the matter is, they finally have the energy to kill themselves. Before starting their antidepressant med, they were so physically, emotionally, and psychologically exhausted, they couldn't plan their own suicide. When they start on these meds and they start to get some energy, they get enough energy to start to make a suicide plan and enough energy to carry it through. This is super important that you understand. This is a huge risk in starting antidepressants. In this slide embedded, you have a nice short video that explains to you how an SSRI works. SSRIs are the first-line treatment now for depression. That means they're usually prescribed first. So you'll see a lot of them. Psychopharmacology, SSRIs, how do they work? Let's take a closer look. SSRIs alter the duration of the availability of serotonin in the neuronal synapse. They also alter the sensitivity of the receptor site. These actions increase the effectiveness of serotonin. SSRIs have less meds that they interact with when compared to other meds for depression. That's another reason why they're often the first-line treatment. Common side effects. SSRIs have fewer cholinergic side effects. Oh God, she just said cholinergic. What does that mean? Dry mouth, blurred vision, urinary retention. Don't remember? Go look up what's a cholinergic side effect. SSRIs also have less cardiotoxicity and a more rapid onset of action than the tricyclic antidepressants. So, some of our big side effects include sexual dysfunction. Up to one-third of patients who take SSRIs experience sexual dysfunction. Sexual dysfunction, do you know what that means? No orgasm. So that is the most common reason that people will self-discontinue taking an SSRI. Also common is nausea, diarrhea, weight loss or weight gain, and sleep disturbances. One of our scary side effects with an SSRI is hyponatremia. This has been reported, and it's more common in the elderly. Overdose. There is a lower risk for overdose than compared to tricyclic antidepressants or TCAs. Pregnancy. Most SSRIs are a class B and should not be taken in the first trimester. Paxil, which is one of the brand name SSRIs, is known to contribute to birth defects and a class D medication. Serotonin syndrome. This is important. Please click on the link in your regular PowerPoint and read the NIH Medline article on serotonin syndrome. Serotonin syndrome is most likely to occur when an SSRI is just started or when the dose is increased. The use of SSRIs in combination with another class of antidepressants known as MAOIs has resulted in fatalities. If a client is changing from an SSRI to an MAOI, they must be off the SSRI for a certain period of time. It's typically around 5 weeks, but that's not every SSRI. So you have to know the individual half-life of each of the drugs and what the manufacturer's recommendations are for how long the time is that they have to be off the SSRI before starting the MAOI. Most doctors won't prescribe an SSRI and an MAOI together because there's just too many other safer choices you can make. If somebody uses St. John's wort or tryptophan in combination with an SSRI, that can also cause serotonin syndrome. Withdrawal. Patients should be taught not to discontinue SSRIs abruptly due to the potential of the experience of somatic and psychological symptoms of withdrawal. Patients typically taper on and taper off most psychiatric drugs. Remember, we go low and slow. Slowly build up, slowly come off. So please, please, please look at the tables in your book and review the different SSRIs, their potential side effects, the advantages and disadvantages of each. How are you going to help your client who's taking these meds? Like, what if you have a client that's taking Celexa and they complain of a headache? What are you going to tell them? Look, the fact of the matter is a headache is a known side effect for Celexa, and if they'll just wait a few days, usually it'll go away. Psychopharmacology, atypical antidepressants. How do they work? We're going to look at 3 of the atypical antidepressants. They all work a little bit differently, so we're going to look at them individually. Wellbutrin is still widely prescribed. It works by blocking the reuptake of norepinephrine and dopamine. Wellbutrin is also a stimulant and can be used in treating smoking cessation under the name Zyban. People like Wellbutrin because it has less of most of the undesirable side effects. You have less weight gain. In fact, Wellbutrin, you may experience weight loss, and it has much less sexual side effects, The most common side effects are GI related, like nausea and anorexia or weight loss. Wellbutrin also may contribute to insomnia or anxiety. So, is this the best drug for a patient who has depression and also has an anxiety disorder? No. Let's look at Remeron. Remeron works by enhancing norepinephrine release and antagonizing serotonin receptors. It's not a reuptake inhibitor, but it increases serotonin and norepinephrine. It's good for severe depression and insomnia. The most common side effects are dry mouth, abnormal dreams, vivid abnormal dreams, confusion, and sedation. The risk with Remeron is weight gain, and I mean serious weight gain, and serious sedation. This medicine is unique in that Remeron has the only dissolvable form for an antidepressant. The Remeron Saltab will dissolve on the tongue in approximately 30 seconds. So you've got a dissolvable antidepressant. What kind of patient do you think this is good for? I'm going to let you answer that for yourself. Trazodone's not available as Deseril anymore in the US. Deseril was the brand name. Trazodone is only available in its generic form. I bet a lot of you in your clinical have seen this used already. Trazodone works by inhibiting the reuptake of serotonin, norepinephrine, and/or dopamine. It's really not used as an antidepressant anymore, but it is used as an adjunct therapy to treat the insomnia that's caused by other antidepressants. It's typically given on a daily basis at night. Psychopharmacology, dual action reuptake inhibitors, or SNRIs. These are our newest antidepressants. Remember the Prestige commercial? Well, here's the Cymbalta commercial. It's embedded. Remember, you have to go on the regular PowerPoint to play that. This is really a terrible commercial. I don't know if that DJ is depressed or he's just sick of playing It's Raining Men over and over again. But that commercial does a great job of listing all the side effects. So you're going to see Cymbalta prescribed. You're actually going to see it prescribed for fibromyalgia and diabetic neuropathy. So make sure and check with your med-surg patients. They may not be depressed if they've got Cymbalta because it may be actually for diabetic neuropathy, which it's been recently approved for. How do SNRIs work? They stop the reuptake of serotonin and norepinephrine, which makes both of these amines more available. SNRIs are typically prescribed for major depressive disorder. The most common side effects are GI related. Somebody may have a headache, insomnia, and sexual dysfunction. Risks with SNRIs include hyponatremia, liver toxicity, and hypotension. Psychopharmacology. Tricyclic antidepressants. Tricyclic antidepressants were a major breakthrough in psych meds. They were first discovered from antihistamine compounds. They were first used in the 1950s, and they're still in use today. Mostly, though, they've been supplanted by SSRIs and SNRIs. Elavil, which is a drug you've probably heard of, has been around since 1961. So, how do TCAs work? They function by the non-selective inhibition in the reuptake of serotonin and norepinephrine. Although patients will experience benefits from treatment and a reduction in their symptoms of depression, there's a lot of unpleasant side effects. So when you think about their side effects, remember what they were derived from, antihistamines. So think about the effects of antihistamines to understand their common and adverse side effects. Some of the common ones are related to the anticholinergic properties. So you're dry like the desert, dry mouth, constipation, blurred vision. You'll also have a reduced sex drive, and you might have cognitive changes like sedation. TCAs have risks. These anticholinergic effects of the TCAs can pose a great risk to the cardiovascular system, such as orthostatic hypotension. What do we worry about with orthostatic hypotension? People can experience cardiac arrhythmias and possibly even a myocardial infarction or an MI. TCAs can cause urinary retention and constipation that actually requires medical intervention. We don't use Elavil, one of the TCAs, the one you see pictured there, with the elderly, because Elavil has some severe cardiotoxic effects. TCAs undergo extensive metabolism by the liver, so they interact with a lot of our common meds. That makes TCAs either less effective or makes the other medications less effective. So, if you have a patient who is on a TCA, you have to look up in your Davis drug guide to see if it's going to interact with other medications they take. Titration is super important and necessary for starting and stopping TCAs. So it can also take up to 2 months for the full effects of the drug to happen. And once you start on a TCA, you really need to stay on it for 6 to 12 months to see if it's working. If TCAs are used in the elderly, it is super, super, super important that we go low and slow on them. Now, you can overdose on TCAs because the therapeutic level for a TCA has a very narrow range. We don't do lab tests to test TCA therapeutic levels, but there's a narrow range, so the difference between it being therapeutic and lethal isn't that far apart. People have either overdosed on TCAs either on purpose or accidentally, and that's the reason mostly we're going to go with an SSRI or an SNRI first. Psychopharmacology, monoamine oxidase inhibitors or MAOIs. Aren't you glad you paid such close attention in your pharm class and to the lecture that you got from the chapter that had all the medications? Because all of this is just a review for you, right? I know. So, MAOIs. These are our oldest antidepressants. These have been in use since the 1930s. What's interesting about these is it was discovered because they were using a drug called ipronizid. It's not in use anymore. Anyway, a drug to treat TB. And when they gave the TB patients this ipronizid, they saw a mood elevation in the TB patients. So somebody said, oh, look, they're feeling better. Let's give it to depressed patients. MAOIs are hardly used now. MAOIs are the drug of last choice because there's so many restrictions for a client who's on an MAOI. How does an MAOI work? Monoamine oxidase inhibitors. The name tells you how they work. They stop or inhibit the chemical breakdown is oxidation, of the single amine chemical molecule, a monoamine. So if those molecules, dopamine, norepinephrine, and epinephrine are not broken down, then they're available to bathe the synapse. And a dopamine bath is good. However, MAOIs are not our best choice. While they stop the breakdown of our happy chemicals, they also stop the breakdown of other monoamines called tyramine. Another monoamine called tyramine that's found in food. Please check your textbook for the list. It's super, super, super important that you know what foods somebody who's on an MAOI cannot eat. If tyramine is not broken down, you can have some very serious and deadly effects. Side effects of MAOIs. The adverse reactions include hypotension, so you have to be very careful what other meds your patient's taking. See the graphic on the picture that's on this slide? It talks about what meds they can't take because there's a lot of terrible drug interactions with those. Another side effect that's common with other antidepressants is the anorgasmia. Risks with MAOIs. The big risk with an MAOI is a hypertensive crisis. A hypertensive crisis is a medical emergency and something you have to know the signs and symptoms of. Yes, it's in your book. It's probably in a box. Hypertensive crisis can happen from eating foods high in tyramine while on an MAOI or combining an MAOI with other popular meds. So that's where we say if you're on an MAOI, no popular meds. And NPM also helps you remember the names of the MAOIs. How convenient is that? Psychopharmacology, ketamine. Ketamine is an anesthetic, actually. Ketamine is also known as the club or rave drug Special K. Ketamine is the newest promising pharmacology to treat depression. So how does it work? Ketamine blocks glutamate reception at the cell, which essentially shuts off communication between the brain and body. That's why ketamine is a party drug. But that's not how it works to treat depression. When your body breaks down ketamine, it creates a chemical byproduct that's called a metabolite, a chemical byproduct of the breakdown of a drug as a metabolite. The metabolite treats the depression. So in 2016, the metabolite was isolated and it creates the effects of reversing depression symptoms without the anesthetic or addictive effects of ketamine. So far, clinical trials have shown that this metabolite can lift depression in as short as 2 hours and usually in 3 days, and it lasts. It's been licensed to be used as a, quote, breakthrough therapy by Johnson & Johnson, and it's going to be available as a nasal spray. I suspect it will only be used for treatment-resistant and suicidal or homicidal patients while we have it on the market a while to ensure it's safe and effective. So there's a link there in the notes for you that tells you about the NIH research on ketamine. And if you're interested in learning more about clinical trials for depression, or you have a patient who is, I put a link to the US government site for how to get in or learn about clinical trials. There are new meds for depression almost yearly. Remember, depression is the #1 reason for disability in the United States. You will be taking care of depression, and you have to keep up with the latest treatment and meds. You can pause the PowerPoint here if you'd like to review the slide on A&P and the meds for depression. This is here for you to review. It's got some good information in it. Let's talk about some other medical treatments for depression. They include somatic therapies and complementary alternative medicine. We are only going to review ECT or electroconvulsive therapy. For the other somatic therapies, you must watch that video that is in your other PowerPoint about ECT from UCLA. Remember, ECT is a procedure. People have to sign an informed consent. They must be NPO after midnight. They have to void before the procedure. They're given a light anesthetic and a muscle relaxant IV. Their family and friends may be present. There's some short-term memory loss after ECT and possibly some mild confusion. There are mixed studies about the efficacy of ECT, but the most recent research that was published by the Psychiatric Nurses Association says that ECT is effective. If you end up working in an area where this treatment is available, you have to stay current on the research. Please consider your role as a nurse in the use of ECT. What do you need to check with the patient before and after the procedure? What vitals do you need to do? Do you have to be sure that they voided? What are your safety concerns? Think like a nurse. Let's talk about complementary and alternative medicine, or CAM. St. John's wort has been proven to be largely ineffective. That's an herb. Supposedly it was a miracle plant about a decade ago, and some folks still swear by it. It could be a placebo effect. It interacts with about every medicine in the Davis Drug Guide, and you have to specifically ask your clients if they use it. If they've had a history of depression, especially ask them if they've used it or still using it, rather. Don't just say, what herbs do you take, but ask them, do you take St. John's wort? Peer support and diet and exercise is good for everybody, depressed or not, but in the depressed client, it's really essential to their well-being and recovery. Psychotherapy. Psychotherapy is usually combined with meds for the treatment of depression, and this is considered the most effective, and I wish I could tell you it's the most widely used, but often what we're seeing now is just medication and not the therapy. But why should we and why do we combine meds with therapy? So meds help with your thinking, meds help your brain function better, and therapy helps you learn long-term lasting behavioral changes. That's why it's so important. The goal for therapy is remission from symptoms. We want to see a psychosocial restoration. We want to prevent relapses and increase people's compliance with their treatment and improve their roles in relationship. So some of the common ones are milieu therapy. Remember, milieu therapy is usually used in inpatient crisis therapy. It's supportive. There's a structured environment. We want to prevent harm to self or others. And during the milieu, interpersonal therapies are employed to enhance coping skills. Behavioral therapy, got a little chart there about it. It's used to reinforce positive interactions, decrease your negative interactions, and improve your social skills. Cognitive therapy is used to correct cognitive distortions. So folks who have depression have black and white thinking. They personalize everything. They magnify their events or minimize certain events. They may have specific abstractions. A specific abstraction is where one detail tells the whole story. They focus on one little detail of an interaction. It's usually negative, and then they discount all the positive aspects of that interaction. They also have something depressed folks called arbitrary inference. Arbitrary inference means you jumping to conclusions constantly. So cognitive therapy is used to correct those distortions. Interpersonal therapy is to help with our relationship difficulties and to help us accomplish our developmental tasks. Major depressive disorder in the nursing process. Let's look at application. So we're going to talk a little bit about components basically of the care plan and the nursing process. So start with assessment. What do we expect to find in depression? A depressed person in their history, we're going to find that they tire easily. So we have to use short, easy to understand sentences and allow adequate time for the interview. Ask them what their perception of the problem is. What brings you here today? Not why are you here? Why is a challenge? What brings you here today? Ask when their behavior changes started, what the duration of their behavior changes are, and what they've done about it. What they've done about it, when we ask that question, we've got to assess for alcohol or drug use. We've got to find out if they've had a history of depression, if they've been diagnosed before, have they had any treatment for it, and what's their family history. And here you have to ask about suicide. General appearance. How do you think a depressed patient looks? Often they look sad, gray, uncared for, but sometimes they also look anxious. Motor behavior. In their motor behavior, you may see that they're moving very slowly. They may be slow to respond. You have to give them time to respond. They may be pacing, or they may be hand-wringing if they're agitated. In their mood and affect, the mood for a depressed patient is anergia and anhedonia. They may feel guilt, worthlessness, hopelessness, and helplessness. The hopelessness and helplessness may manifest as anger or agitation. Thought process and content. They think slowly, and they think very negatively. They may ruminate. What does ruminate mean? They often have thoughts of dying or suicide. In their sensorium and intellectual processes, some are disoriented. Their memory may be impaired. They can't concentrate, and some folks with depression may have psychosis. And in their psychosis, they hear voices. What do you think those voices are saying? Not good things, and sometimes things that encourage suicide. So we have to ask about that. When we assess their judgment and insight, we find that they can't make decisions. They have extreme apathy. They don't care about anything. Their insight may be intact. That means they know the consequences of what is happening. Continuing with the assessment, when we assess their self-concept, what we find is that general feeling of worthlessness. They often feel their loved ones would be better off without them. Assessing their roles in relationships, we find that depressed patients experience great difficulty in their roles in relationship. Their families, as well as them, need to be educated about depression. Their loved ones may have said things to them like, "Why don't you just snap out of it?" So we have to teach what depression is and that you can't just snap out of it. Psychological and self-care considerations. Depressed patients often experience insomnia, weight loss. They have no sexual interest. They may have poor hygiene, and often they're constipated. So there are a few depression rating scales. There's probably hundreds, but there's a few that are most commonly used. Some are short and some are very long. Part of your assessment is going to be to use one of these tools. Primary care physicians usually use a very short screening tool as part of their yearly visit. Please, if you're an office nurse, read it and follow up if there's any indications of depression. True or false? Clients with depression often exhibit anhedonia. I think you know the answer to that one by now. Major depressive disorder in the nursing process, application continued. Data analysis. So your textbook lists some common nursing diagnoses for depression. Be sure and read through those nursing diagnoses that are appropriate. A common one you're going to see is ineffective coping. The NANDA definition on that is the inability to form a valid appraisal of the stressors, inadequate choices of practice responses, and/or inability to use available resources. Fairly common with depression. You want to identify outcomes that would reflect improved functioning of the depressed patient. Emphasize that priority behavior is freedom from self-injury. Remember, we have to keep our clients safe. So our outcomes are meant to improve functioning, but what is our priority? It's always safety. So here's a couple. Safety, improved self-functioning, and improved physical condition. So we may want to see that they've got an improved mood and energy, that they're going to be able to return to their previous functioning levels, that they're going to comply with their medications, among others. It's going to be very individual for your patient. Major depression and the nursing process, application still continued. Now we're going to talk about interventions. So let's talk about our appropriate interventions to provide for safety. How are we going to develop our therapeutic relationship, promote daily functioning? How do we use our therapeutic communication and manage medications? So these are some examples. Providing for safety. In some facilities, you may see suicide precautions, so be sure you're following your facility policy. Remember, you have a legal and an ethical responsibility to report suicide and to prevent it from happening. To avoid repetition, we'll talk a lot more about suicide and the safe environment when we are doing our bipolar lecture. We're going to promote therapeutic relationships. We can spend non-demanding time with our patients. So while you're there, please don't be too cheerful. But what can you do to comfort them? You can give them time. Give them your time. Be willing to sit in silence. Be a presence. Understand with depression, their disease has driven off a lot of their support system, and the loneliness is overwhelming because there's also physical loneliness. And you just being there for them can provide a comfort and promote that therapeutic relationship you want. We want to promote ADLs. We want to have good physical care of the self. So you might have to use short, concrete messages when you're trying to get somebody with depression to do an ADL. They may not respond to a global task. A global task is something like, let's wash up and get dressed. So instead of that, you may have to say something like, here is a washcloth, wash your face. You might even have to assist them and say, I will help you by wetting and wringing out the washcloth. Here it is, now wash your face. So you may have to assume an authoritarian role. You're going to be the one in charge. It is time to wash your face. Don't ask if they want to. People with depression do not want to wash their face. You have to have them complete one task at a time. Why? Because with depression, the thinking is so impaired. You can't say, first you're going to wash your face, then you're going to brush your teeth, then you're going to do this, then you're going to do that. They can't remember that. They can't keep it straight. One task at a time. So why is self-care important? Don't you feel better when you wash your face? Why do we sit with our depressed patients when we offer them food? Because it's better to eat with somebody else. You're more likely to get nutritional compliance. Rest is very important. I hope all of you have looked at sleep hygiene as one of your interventions with some of your patients. You can offer a sleep aid for sleep, and depressed patients need to get out of bed during the day. Why? Why do you think you need to get out of bed? It's important to be physically active and to not be in the sleeping place when you should be in the awake place. Let's use our therapeutic communication. We can use things like restating or broad openings. We can encourage descriptions, validation, making observations. Oh, she just used a lot of communication skills. You might want to go back and review those and see which ones work best for a depressed patient. We have to avoid platitudes and cliches. We say those to our patients to protect ourselves, not to help the patient. If you say to them, it's always darkest before the dawn, well, how does that help them get better? And really, what does that mean anyway? With depressed patients, you really have to consciously use your therapeutic communication skills. It can be really hard, and you have to restrain yourself from wanting to fix them with your advice or doing everything for them. You have to stop yourself from talking when silence is what's really needed. Managing medications. Often we, the nurses, are the resource for the medication information. So you've gone over meds already in your class with a previous lecture, you've had a pharm class, you should know some effects and the nursing implications. And I gave you a lot of details in this lecture too. I'm guessing this is all super important for you to know as a nurse. Please look over the stuff in your book. Compliance is extremely important for your patient with medicines, and you're their educator. Client and family teaching. You can and should educate the patient and their families about their illness, what their treatment is, and what a relapse looks like. How will you tell the family about meds? How will you tell them about signs and symptoms of a relapse? Well, the symptoms return. You need to tell people about support groups too. So, our evaluation, it's very individual to each client with depression and individual to their achievement goals. But successful treatment outcomes overall are that the patient feels safe and don't feel uncontrollable urges to commit suicide. Anything more than that is even better. Depression is actually very common among the elderly, and 60% of you will be working in long-term care. That's what statistics tell us about LVNs. So it's really important that you are cognizant of depression in the elderly. Now remember, with the elderly, things present differently. So with the older folks, psychotic features and depression are more common. Older folks are less tolerant of the medications that we use to treat depression. They're starting to use ECT more commonly because there's a more rapid response. And remember, suicide is not limited to teenagers. Suicide is actually quite common and is increasing among elderly people. Finally, let's look at some self-awareness issues. Nurses are often the first healthcare professional to recognize behaviors that are consistent with mood disorders. You may be the first person to recognize a suicidal patient or a friend. You have to know the signs and how to respond and help them. Think about how your culture and values may affect your care of a client with depression or one that might have attempted suicide. How will you feel about them? Working with depressed clients can be frustrating. We are so used to fixing things, and recovery from depression can be really slow. You must care for yourself. You could try journaling to deal with your feelings. Be sure you talk with your colleagues, because that's often helpful. Make sure that you get enough sleep and regular exercise, and implement good coping strategies to create protective factors for yourself as a nurse.